Another topic that is of interest is the fact that since 2004, we now know that there is a role to treat individuals after surgery with chemotherapy, that's called adjuvant chemotherapy, if they had evidence of nodal metastases in the specimen that was removed. So if they were stage 2 or stage 3 tumors, we now have a fair amount of data to support these individuals should be considered for chemotherapy after surgery or adjuvant chemotherapy. There's more of a debate for the stage 1B tumors, which have not spread to lymph nodes, but some of those can be fairly sizable. And at around 4 centimeters, it's worth a discussion that maybe tumors that are 4 centimeters or larger, even if the lymph nodes are not involved, maybe these individuals should be considered for chemotherapy, but that's a topic by itself. The advantage of adding chemotherapy after surgery is statistically real. And we've had 4 trials, 2 in North America, 2 in Europe that have shown this. But the advantage is not, in baseball terms, it's not a home run. It's a single, maybe a double, but it's real. So I think it's reasonable to tell your patients that if you're going to have chemotherapy after surgery, in those situations, you can expect a 5% as high as a 14. So between 5 and 14% improvement in your odds of curing the cancer by adding chemotherapy. And chemotherapy should be 3 or 4 cycles or treatments after surgery, with cisplatin being one of the agents. Now, one of the debate or question is, why couldn't we give the chemotherapy before surgery? Why do we have to do it after surgery? Well, that's a topic that was very close to my heart for years, and we actually were studying this concept of giving chemotherapy before surgery at a time where the data to support post-operative chemotherapy became standard of care, and as a result of that, almost everywhere, we stopped studying the concept of giving chemotherapy up front. There are potential theoretical advantages of giving the chemotherapy up front before surgery, and that's called induction chemotherapy. And the first one is that you potentially may control the micrometastatic disease, the little cells that are floating around early on before it's too late. You may potentially take a tumor that's fairly large, shrink it down, and allow you to do less than a major resection. Maybe you do a lobectomy instead of a pneumonectomy, so that's debatable. You have an idea whether your drugs are working because you can follow the tumor on X-ray and see if the tumor, or on PET scan, and see if the tumor is shrinking as a response to the chemotherapy, which is potentially an advantage to the oncologist, particularly when the chemotherapy is a little hard on the patients. Because once you do your chemotherapy after surgery, the X-rays are not normal. There's no tumor around. So we're doing it, but it's kind of a shot in the dark because you can't see whether the tumor is responding or not. And the final potential advantage is that there may be more easiness in giving the chemotherapy before surgery, because that's always been a bit of an issue when you're trying to give it after surgery. Your intentions are there, the patients started, but they're still recovering from surgery and you're not able to give it. So maybe what we call the delivery of chemotherapy maybe in the 70–75% range after surgery at best. And then if you give it before surgery, it's probably 10 to 15 points higher. Whether or not that translates into better results, we don't know right now. So these are advantages. And the fact is that when we look at the studies that were done studying the question of induction chemotherapy, and we group them all together, we come up with what's called a hazard ratio, which evaluates the effect of your treatment, very, very similar to the hazard ratio of giving the chemotherapy after surgery. So there are who believe that these two strategies are very equivalent. There are who also believe that maybe actually induction is a little better, but right now it's a subject of debate.